The title of this module is Fluid and Electrolyte Imbalances. The learning objectives of this module include describe the etiology, laboratory diagnostic findings, clinical manifestations, and nursing and collaborative management of the following disorders: extracellular fluid volume imbalances, sodium, potassium, magnesium, calcium, and phosphate imbalances. Describe the indications of common intravenous solutions. Some common types of IV fluids are listed here. We have D5W, which is 5% dextrose in water. It is isotonic, but it is physiologically hypotonic. It can be used to treat hyponatremia, but it does not provide any electrolytes. It does provide a small amount of calories as well. Half normal saline, or 0.45 normal saline, is a hypotonic solution, typically used to replace fluid loss. It's a maintenance solution, which means sometimes it'll be continuously running on patients, but it does not provide any other electrolytes. 0.9 normal saline is isotonic. It expands the volume, replaces fluid loss, but also does not provide any electrolytes. When using 0.9 normal saline, you have to watch your patients for fluid overload, which might be signs of decreased urine output, crackles in the lungs, edema in the lower extremities. And this is the solution that is administered with blood. It's the only solution that can be administered with blood, and most of the time it's the solution that's administered with antibiotics because it is typically compatible with everything. D5-45 normal saline and D5.9 normal saline are hypertonic solutions. They're typically used to treat hypovolemia, hyponatremia, and again they do provide some amount of calories. Lactated ringers is isotonic, and it's very similar to the makeup of plasma. It does not provide any free water or calories, but it does contain some electrolytes. It does contain sodium, potassium, chloride, calcium, and lactate. Fluid and electrolyte imbalances typically occur because there's been some disruption to the normal homeostasis, and this can be caused by illness or disease. Some common ones might be burns. Typically, if someone has a burn, they will be hypovolemic. A person with heart failure will be hypervolemic because they are fluid overload. There are sometimes therapeutic measures that can cause electrolyte imbalances as well, such as too much IV fluids can cause fluid overload and electrolyte imbalances. Also, if the fluids contain electrolytes and the patient is having difficulty excreting the electrolytes that are being taken in through the IV fluids, such as a patient with renal failure, you could see hypervolemia as well as increased, let's say, potassium levels. Diuretics, especially thiazide and loop diuretics, can often cause electrolyte imbalances. It can affect the sodium, the chloride, the magnesium, and the potassium, but most oftentimes with diuretics it will be the potassium that is affected. And oftentimes our postoperative patients will have fluid and electrolyte imbalances. This can happen from the fact that they've been NPO for possibly an extended period of time. It may be the bowel prep that they had to take prior to surgery. It can be from blood loss during the surgery, and it can be from fluid shifts that occur during and after surgery. There are two types of fluid imbalances. One is fluid volume deficit, also referred to as hypovolemia. And typically this is from a fluid volume deficit that occurs with abnormal loss of body fluids. So it can be from diarrhea, hemorrhage, polyuria, and diabetes insipidus are some of the common causes. Fluid volume deficit should not be used interchangeably with the term dehydration, because dehydration refers to loss of pure water alone, and it does not have a loss of sodium. Fluid volume excess, or hypervolemia, is the abnormal retention of fluids. And this can happen from patients who have excessive IV fluid administration. You'll often see this with heart failure and renal failure patients, patients with syndrome of inappropriate antidiuretic hormone, as well as Cushing's disease. So a lot of times if you are observing a patient who has fluid volume excess, like I said previously, you're going to oftentimes hear crackles in their lungs. Maintaining normal electrolyte levels is very important. Sodium plays a major role in maintaining the concentration and the volume of extracellular fluid. You need a normal sodium level to generate and transmit nerve impulses, and it's also needed in the regulation of acid-base balance. Typically, sodium is taken in through the food that we eat and absorbed through the GI tract. Typically, the average person exceeds the daily amount of sodium required. Sodium is, though, excreted through urine, sweat, and feces. The kidneys regulate the extracellular fluid concentration of sodium by excreting or retaining water under the influence of the antidiuretic hormone. Hypernatremia, or elevated sodium levels, can be caused by several different factors. One can be impaired level of consciousness, so this may be someone who is not drinking enough fluids. And also can happen by a decrease in the kidney's response to the antidiuretic hormone, which can result in profound diuresis, which produces a water volume deficit and hypernatremia. It can also happen from hyperglycemia, associated with uncontrolled diabetes. And in these situations, you have osmotic diuresis, so dilute urine is being lost, leaving behind a high solute load. Excessive hypertonic saline administration can increase the sodium levels. Excessive oral intake of sodium with a decreased amount of water intake can lead to hyperglycemia, as well as concentrated enteral tube feedings. So with an elevated sodium level, oftentimes there's water loss and sodium gain. And because hypernatremia causes hyperosmolality, there is a shift of water out of the cells, which leads to cellular dehydration. So because of the cellular dehydration, you also have dehydration of the brain cells. So you may see someone who has intense thirst. They may be lethargic, agitated. In severe cases, they can have seizure or coma. You might see postural hypotension, weakness, lethargy, and decreased skin turgor. So in order to treat the imbalance of hypernatremia, we want to, if we know the cause, treat the cause first. Otherwise, we can push fluids. We can start an infusion of D5W. We may restrict their dietary sodium intake, but what is important to remember is that the sodium levels must be reduced gradually. If we decrease the sodium levels too quickly, it can result in cerebral edema and can have long-term cognitive deficits for your patient. Hyponatremia, or low sodium levels, can be caused from excessive hypotonic IV fluid administration, excessive PO water intake, the syndrome of antidiuretic hormone, which causes water retention, and therefore sodium is then diluted. It can also happen from sodium being lost from the GI tract, kidneys, or the skin. Hyponatremia causes hypoosmolality, which is a shift of water into the cells. So fluid also shifts into the brain cells, and this is why you'll see irritability, confusion, seizure, and sometimes coma. And in severe cases, there's irreversible brain damage and death. So first we'd want to try to treat the cause if we know what the cause is. Otherwise, the most common way to decrease the amount of water intake and increase our sodium levels would be to put the patient on a fluid restriction. So we would restrict the total amount of fluid, water, and all other fluids that a patient can intake within a 24-hour period. In severe cases, we would do slow administration of an infusion of 3% normal saline. Potassium is a very important electrolyte. Potassium is the major intracellular cation. Normal potassium levels are critical for cellular and metabolic function. You need adequate potassium levels in order to have appropriate transmission and conduction of nerve and muscle impulses, cellular growth, maintenance of normal cardiac rhythms, and an acid-base balance. Potassium is something that is needed daily from dietary intake, and the average person needs approximately 50 to 100 milliequivalents of potassium a day. 90% of daily ingested potassium is excreted by the kidneys, but there is also some that is lost in stool and through sweat. Hyperkalemia, or high potassium levels, is most often caused by someone in renal failure. The person is unable to excrete the potassium through their urine. Excessive PO intake, or someone on parenteral nutrition. If there is massive cell destruction, such as someone who has burns. Sometimes there are medications that can also cause hyperkalemia, such as K-sparing diuretics or ACE inhibitors. And also someone with adrenal insufficiency. Sometimes they have retention of potassium because they have increased aldosterone levels. So the manifestations of hyperkalemia, usually there's an increased cellular excitability, meaning that they might have leg cramps, weakness. In severe cases, they may have paralysis of skeletal muscles. Because our heart is a muscle, we're very concerned with our patients who have hyperkalemia that they're going to have irritability and irregular widening of their QRS when you're looking at an EKG strip. Common dysrhythmias that can happen for patients who have elevated potassium levels would be ventricular dysrhythmias, such as ventricular fibrillation, ventricular tachycardia, preventricular contractions, and in severe cases, asystole. So if we know the cause of the increased potassium level, we'd want to treat the cause. We can eliminate or decrease the amount of potassium that is taken in orally or parenterally. We have to do cardiac monitoring when our potassium levels are high because of that increased risk for ventricular dysrhythmias. We'd want to try to get rid of the potassium somehow, so we can do that a lot of times through elimination. So by administering loop or thiazide diuretics to our patients, that will increase the output of potassium levels. There's also medications like K-Exolate, which can be used, which will absorb the potassium and have it excreted through the stool. We can increase their oral intake. Of course, we have to make sure that that's appropriate for this patient, but if we increase their oral intake of fluids, hopefully that will help increase their urinary output, decreasing their potassium level. We can also give our patients IV glucose, but first we would give them IV insulin. So we would give them insulin IV push followed by the glucose. And what this does is this is going to force the potassium from the extracellular fluid to the intracellular fluid. And we have to follow that with glucose because when we give someone IV insulin, it's going to cause hypoglycemia. So we would give the IV insulin first, and then we would give the glucose. We can also give IV calcium gluconate, and typically this is given just to decrease the excitability of the cardiac muscle. This will do nothing to decrease the potassium level. It's just going to decrease the negative effects that high potassium can potentially have on the heart. So our priority would be to give IV insulin followed by glucose, then give an administration of IV calcium. Hypokalemia, or low potassium levels, results from a shift of potassium from the extracellular to the intracellular. Typically this is caused by loss of potassium either through the kidneys, the GI tract. So you might see this in someone who's having severe diarrhea, someone who's using laxatives inappropriately, a patient with prolonged vomiting who hasn't been able to take in oral potassium, someone who has an ileostomy. We can see that sometimes because the potassium from their dietary intake is not fully absorbed when someone has an ileostomy. It can happen with patients with elevated aldosterone levels, patients in metabolic acidosis, and in the treatment of DKA, because someone who has diabetic ketoacidosis, we're giving them continuous insulin infusions, where we just talked about on the previous slide that insulin is given to decrease potassium levels. So someone who's on a long-term insulin infusion, a side effect would be hypokalemia. So typically the person is going to have increased negative charge of their cells, which is going to cause reduced excitability. So this can result in lethal ventricular dysrhythmias similar to hyperkalemia. If the patient is on digoxin, low potassium levels can sometimes increase their risk for digoxin toxicity. You may see skeletal muscle weakness and paralysis, and typically this happens in the lower extremities. And in severe cases, you can see respiratory arrest. Of course, we'd want to try to treat the cause if we know what it is, but if we don't, we're going to give them potassium chloride supplements in order to get the potassium level up to where it should be. And this can be done through IV piggybacks or oral forms, which can come in some different type of forms where it may be a pill and may be a liquid. We can also instruct our patients to increase their PO intake of potassium. Such foods may include bananas, orange juice. Again, this would be a patient that we'd want to make sure is on a cardiac monitor so we can monitor for those ventricular dysrhythmias. And one thing we must remember is that IV potassium is never given IV push. Given too fast could result in an increased potassium level too quickly, which could result in, again, lethal ventricular dysrhythmias. So IV potassium is always given over, depending on your dose, an hour to 2 hours, and given in an IV piggyback or IV secondary bag. Typically, calcium is obtained from the food that is ingested. However, only about 30% of the calcium from foods is absorbed in the GI tract. More of the body's calcium is combined with potassium and concentrated in the skeletal muscle system. The functions of calcium are the transmission of nerve impulses, muscle and myocardial contraction. You need adequate calcium for blood clotting and for the formation of strong and healthy teeth and bones. Hypercalcemia, or elevated calcium levels. In 2/3 of the cases, it is caused by hyperparathyroidism. 1/3 is caused by malignancies, typically breast and lung cancer. And this malignancies cause hypercalcemia because of the bone destruction from tumor invasion or through tumor secretion of a parathyroid-related protein, and this stimulates calcium release from the bones. It can also happen from excessive calcium intake, which sometimes can be just from the dietary intake of calcium, but it can also happen from someone taking too many antacids that contain calcium. Prolonged immobility can also result in bone mineral loss, which increases plasma calcium concentration. So signs and symptoms you might see is reduced excitability of muscles and nerves. They may have decreased memory, confusion, disorientation, and fatigue. So again, if we know the reason why the person has hypercalcemia, we treat that cause first. But other ways we can get the calcium levels down is we can promote excretion through a loop diuretic. So we would give a diuretic such as Lasix that will promote the excretion of the calcium through urination. But because we're giving this to someone who probably is not fluid overload, we have to then make sure we hydrate them. So we can either hydrate them with isotonic IV fluids or make sure that they increase their fluid intake to 3,000 to 4,000 milliliters. Otherwise, if we think it's from excessive calcium intake, we can have them on a low calcium diet. We can increase their activity, and we can also give a medication called calcitonin. Hypocalcemia, or low calcium levels, can be caused by a decreased production of the parathyroid hormone. This is oftentimes a result of the surgical removal of the parathyroid gland. Other causes can be low dietary intake of calcium. A patient with hypocalcemia may have signs and symptoms of increased nerve excitability. So they may have tetany, they may have decreased contractility in their heart, which may result in ventricular tachycardia. So this would be another patient that would be very important to be monitoring their cardiac rhythms. There are simple tests we can do to monitor for hypocalcemia, which we'll discuss on the next slides. So if we know the cause of hypocalcemia, we'll treat the cause. It's very simple. We can increase their oral intake. We can also put them on PO calcium supplements, and in severe cases, they may need an IV administration of calcium gluconate. If we need to closely monitor our patients for hypocalcemia, we may not want to have a blood draw done every hour or every 2 hours. So some simple assessments that the bedside nurse can do is to test for the Chvátsek sign or the Trousseau sign. The Chvátsek sign, you're looking for a contraction of the facial muscle in response to a light tap over the facial nerve in front of the ear. The Trousseau sign is a carpal tunnel spasm that is induced by inflating a blood pressure cuff above the systolic blood pressure and leaving it there for a few minutes. So in looking at these images, you can see for image A, if you're to tap on that facial nerve, you'll see facial twitching, eye blinking, cheek raising, mouth moving. You'll see that if the patient is hypocalcemic. If you're doing the Trousseau sign, you can see that the blood pressure cuff is tightened and you're seeing that carpal tunnel spasm in the lower extremity, the hand, wrist, finger area. You'll see this would be a positive Trousseau sign. Phosphate, or phosphorus, is the primary anion in the intracellular fluid and is essential to the function of muscle, red blood cells, and the nervous system. It is deposited with calcium for bone and tooth structure. It is also involved in the acid-base buffering system, energy production of ATP, cellular uptake of glucose, and it is also needed in the metabolism of carbohydrates, proteins, and fat. Typically, phosphorus has a reciprocal relationship with calcium, meaning that high phosphorus levels lead to low calcium levels. Hyperphosphatemia, or high phosphate levels, is most often caused by acute or chronic renal failure, and this is because the altered ability of the kidneys to excrete phosphate. It can also happen with patients who are receiving chemotherapy, and this is due to the composition of the chemo. Those who have excessive intake of milk or phosphate-containing laxatives, and those who have a large intake of vitamin D. And this is because those who have a large intake of vitamin D, it increases the absorption of phosphorus from their diet. Signs and symptoms of hyperphosphatemia can include calcium deposits in the joint, arteries, skin, kidneys, and cornea. They also may have neuromuscular irritability. So we'll treat the cause if we know the cause, but one of the nursing interventions that we can do is we can limit foods high in phosphorus, which is typically dairy products. And a lot of times patients don't think of foods high in phosphorus as dairy products. Most people associate dairy products to high calcium, so we'd have to teach them to decrease their intake of dairy products. We'd also hydrate the patient. This may increase the phosphorus to be excreted through the kidneys. And like we said previously, that phosphorus and calcium have an inverse relationship, so if the phosphorus is high, the calcium is going to be low. So if we try to bring up the calcium levels, that should decrease the phosphorus levels. Hypophosphatemia, or patients with low phosphorus levels, are typically malnourished. They have some type of malabsorption issue, or they may be going through alcohol withdrawal. Sometimes the signs and symptoms are very mild, and the patient can oftentimes be asymptomatic. But in severe cases, you'll see decreased cellular function, which can result in cellular death, which we may see CNS depression, confusion, there may be mental status changes. In severe cases, we can also see muscle weakness, pain, dysrhythmias, and cardiomyopathy. So we'll treat the cause if we can, but we'd want to encourage an increased PO intake of phosphorus. There are also oral supplements that can be given to patients. In severe cases, we would give the patient either sodium phosphate or potassium phosphate. You would have to know their sodium levels and their potassium levels in order to decide which one they would get, if it would be sodium phosphate or potassium phosphate. Typically that would be decided by the physician, but you as the nurse administering the medication would want to make sure you're looking at those electrolyte levels as well, because whichever one you choose will be increasing that other electrolyte level as well. So if someone had high potassium levels, we would not want to give them potassium phosphate, because it's going to increase not only our phosphorus level, but our potassium level. And when we're going to supplement phosphorus, we have to monitor our calcium levels, because we already have talked about that when we have increased phosphorus levels, it's going to cause a decrease in calcium. So while we're supplementing this low phosphorus level, it may cause increased hypocalcemia, which may result in them needing supplementation for the calcium as well. Magnesium is the second most abundant intercellular cation. Approximately 50 to 60% of the body's magnesium is contained in the bone. Magnesium functions as a coenzyme in the metabolism of carbohydrates and proteins. Many of the factors that affect calcium and potassium balance also influence magnesium balance. So oftentimes when you're evaluating low potassium or high potassium, low calcium, high calcium, you'd want to be looking at your magnesium level as well, because typically it'll be having the same imbalance as those two. It is very important to monitor magnesium because it is also very influential in normal cardiac function. High magnesium levels are typically caused by acute or chronic renal failure, again because of the kidney's inability to excrete the magnesium. This can also happen from increased ingestion of intake of magnesium-containing products. A few to mention would be Maalox or milk of magnesia. Signs and symptoms of high magnesium levels can include lethargy, drowsiness, nausea and vomiting. Some of their deep tendon reflexes may be lost, and you may see the patient very sedated. There can be, in severe cases, respiratory and cardiac arrest. So, of course, we'd want to treat the cause if we know the cause. Emergency treatment of someone with high magnesium levels would include the IV administration of calcium chloride or calcium gluconate. And typically this is given for the same reason we give it to patients with high potassium levels. We're giving it to oppose the effects of magnesium on the heart. So some of those ventricular dysrhythmias. We can then give fluids to promote urination, which can increase the excretion of magnesium. We can also give diuretics for patients if it's not contraindicated, because diuretics will also cause loss of magnesium. And if the patient is an end-stage renal disease patient, this patient will need dialysis. That's going to be the only way for us to remove the high magnesium levels from this patient who's unable to urinate. So low magnesium levels can occur for a patient who has prolonged fasting or someone who is starving, someone who has chronic alcoholism, or when there is fluid loss from the GI tract, such as someone with prolonged nausea, vomiting, diarrhea. Someone who has been on prolonged parenteral nutrition but hasn't had magnesium supplements, and someone who is on diuretics. Signs and symptoms can include neuromuscular, and CNS hyperirritability. So this can also be someone who might have confusion, hyperactive deep tendon reflexes. You may see tremors, seizures, and cardiac dysrhythmias. So we'd want to treat the cause. We can give oral supplements. We can increase their dietary intake, and some foods are listed here for you that have high magnesium content within them. In severe cases, we can give IV magnesium sulfate. And we want to again make sure that we do not give the IV magnesium IV push or too fast. We would run it over whatever our hospital facility instructs us as the appropriate time, usually an hour or 2 hours, because if we administer it too fast, it can raise our magnesium levels too high, which can result in cardiac and respiratory arrest. So even though when you look in your textbooks and you look in your lab values textbook, the normal values that they give you for potassium and magnesium may be slightly lower than what I list here, but typically for our cardiac patients, we want our magnesium levels and our potassium levels to be a little higher than what they may say for the average person. So oftentimes in hospital acute care settings, we may be supplementing our patients with potassium if it's less than 4 and magnesium if it's less than 1.8. So I challenge you, when you go to your clinical setting next, to look at your hospital policies and see if they have a standard order set for patients to be supplemented. It might be called PRN electrolyte replacement. It might be within your monitored bed orders for your patients on telemetry. But I challenge you to look at your site and see. And if you're on a unit that has patients with cardiac problems, typically these will be ordered for all of your cardiac patients. So you'd want to know that, because when you assess your morning labs for your patients, it would be your responsibility to supplement them if they meet these parameters.